Hey, everybody, welcome back to the Monday Afternoon Journal Club. Ed Bowder, Dan Schwester, and Mike DiFilippo here for the Overrun. And today we are going to talk about a study that comes out of Washington, D.C. Gentlemen, we have talked previously on this show plenty of times about what is the proper drug to actually use when we're trying to save blood pressures. Here we have norepinephrine versus epinephrine after cardiac arrest, a systematic review and meta-analysis. And you know we love our meta-analyses here. This is from Williams et al. And let's get right to the conclusion. Then we're going to go to Mike. So here, after a small number of studies, norepinephrine used in post-cardiac arrest patients were associated with lower odds of recurrent cardiac arrest. However, high study heterogeneity highlights the need for well-designed future research to validate these findings. Dr. DiFilippo, we have spoken to a couple different intensivists here that have spoken to us about using norepinephrine over epinephrine, and we want to know your thoughts.
My thoughts on this are just do everything you can to prevent post-ROSC hypotension.
Great, whether great episode. Thanks, everybody. We'll talk to you all next time.
Great.
Boom, done.
It's been great.
So it's obviously these are very hard patients to study just because of a lot of, as the study itself mentioned, heterogeneity in the types of studies that are performed with these sorts of meta-analyses, aka what they look at, the studies they look at to perform their meta-analysis. And then also, just a lot of heterogeneity in people's clinical practice. I would say if I had to choose, we were talking about this a little bit before the show started, my general way of doing things, both in the hospital and pre-hospital, is for post-ROSC hypotension, starting them. I'm having a norepi drip set already, because we're assuming ROSC, because we're all great compressors, right? Number two, whenever we have
some great manual compressors.
Yeah. Check out our other podcasts for that one.
Don't start.
So, I think norepinephrine is very easily available in most emergency departments. Most EMS organizations I'm running with are carrying norepinephrine, and it's their preferred vasopressor for hypotension now. So I think if the system is familiar with using it, people are familiar with using it, and it's easily available, those are all the green lights for me about being a preferred pressor for post-ROSC hypotension. Because the reason is, there's lots of studies out there looking at these sorts of things, but as this particular study said, there's nothing like gold standard that is like, this is definitively practice changing. Like I said, I think the biggest thing that we've recognized is preventing post-ROSC hypotension is the biggest thing. Whether you're using push-dose epi, you're using norepi, please God, don't be using dopamine. So 2000s of you to be using dopamine. But my clinical practice is a norepi drip, and then as needed, I still like to keep push dose pressors, so push dose epi in my pocket. And if the patient does have some transient hypotension, or something along those lines, just have that at the ready. The question is, if they tank their pressure, if it's a little dip, you can probably just go up on the norepi. If it's a big drop, right? Let's say they've been stable with MAPs in the 70s or 80s or whatever on your norepi, and all of a sudden they drop down to a MAP to the 30s, 40s. That's a huge drop. That's something that needs a little bit more quicker acting than just up titrating a drip, maybe a small bolus of things. That's why I prefer to use a push dose pressor like epi for those sorts of things, for those larger MAP drops. But if it's just like a subtle drop in the MAP or something like that, then just up titrate the pressure that you have them on a drip wise. But yeah, that's my 2 cents on it, is just prevent your post-ROSC hypotension by any means possible, whether that's norepi or epi. Dealer's choice,
whatever works. And that is essentially what we've heard previously from Eddie Gutierrez and people like that who have come on to the show. I think we can start making t-shirts that say by any means necessary, just with a picture of a norepi bag hanging down.
Oh, that's awesome.
It's so good. But Danny, this is all the stuff that we like to see in these studies, right? We already know we love meta-analyses, and I say we, and I mean me. In this actual study here, they looked at 1,217 studies. That's what they screened. They looked at 6 studies overall, which is great because they actually took the time to go through and see what works and what doesn't. These 6 studies involved almost 3,500 patients. So the biggest thing that came out of this, patients receiving norepinephrine were associated with 63% lower odds of having recurrent arrest. And obviously, going into a cardiac arrest scenario, these patients are going to be unstable, right? They're more likely to re-arrest. This kind of confirms what we've talked about previously. What do you think?
Yeah, absolutely. I think the biggest problem that we have is realizing, we all want to celebrate when we get ROSC back. It's almost like spiking a football. We want to give everybody high fives. And we're like, oh, wow, all that work. But you got to understand, and I've said this before, this is a very physiologically unstable patient. Just moving them can throw them back into a cardiac arrest. And we know that hypotension and poor perfusion are huge markers for badness coming down the road. I think the thing to take from this is that, like what Mike said, is you got to be ready with a vasopressor. And look, I understand there's some places in our area, or some places that listen to us, all you got's dopamine. Well, then that's what you got. If you got push dose epi, or that's a thing, or you can do an epi drip. I mean, I can't see, if you're in a program where it does push dose, that you couldn't start an epi drip. I tend to like epi because I think everybody's very comfortable with it. And I think it's very easy for paramedics to work with it because they like it. Norepi is, it's becoming my favorite. I do like it. And I've had anecdotally, I've had good results giving it post cardiac arrest. But I realize not everybody has it. And I realize that the stigma of leave a fed, leave them dead, is still out there. But if we don't get their map up, if we don't perfuse their organs, this ROSC means nothing. They won't survive. It doesn't do us any good for them to die of kidney failure in the ICU. So yes, start a pressor. If all you've got is push dose, go for it. Keep that map. Mike, this is a question I want. I kind of look at 60 to 65 as where I'd like to be, especially with somebody who's showing, we know that one of the most common causes of sudden cardiac arrest is some type of myocardial lesion. What's your take on it?
Yeah, so I target a map of 60 personally, 60 to 65, obviously depending on the condition. But generally that's my go-to. I would say just a learning pearl that I always just like to remind people of, and for listeners who may not know this, a lot of our automated blood pressure machines, whether that's your LifePak, your Zoll, the in-hospital machines, whatever, calculate a map. And then from that, they use proprietary software to create what is the most likely systolic and diastolic pressure. So using systolic blood pressure when you're using automated blood pressure machines is not necessarily the most reliable. That's why I'm always a big proponent of going based off the map. But I think 60 is a good goal to watch for, and 60 to 65 is your good range. I know I said earlier your maps are fine in the 70s, 80s. There is some literature out there too about like getting the blood pressure too high. A map of 70, 80 is fine in my opinion. You don't want to, if it's working, don't mess it up somehow. That's also a common phrase. Yeah, I don't advocate.
Just don't do something, stand there. Sometimes that's all you need to do. If this person's got a good map, let it be. Let's get them in a nice physiologic state and get them to where they need to be. But
if their map is like 85 for 10, 15 minutes, then sure, you can start down titrating your pressor. But don't just automatically begin down titrating in particular based off one elevated map number. Obviously, if you have a low map number, we need to respond to that, because as we keep emphasizing, the hypotension is the thing that really kills these patients.
It drives my partners nuts, especially when it's their chart. But I will also set my monitor to do basically every 2-minute blood pressures. And that way I'm getting as close as I can get. I don't have an A-line. I don't have invasive monitoring, but every 2 minutes, I'm going to get a sign. I'm going to get an idea where I'm going, and I can watch that trend. And
I'm a big advocate of that. I do that if I'm intubating anybody, be it in the field or in the ER, or any high risk procedure where there's going to be some sort of hemodynamic instability or potential for hemodynamic instability. Getting Q 2.5 minute vital signs, that's just the one that's most easily available for me to choose on our monitors that we have. That's what I do, because in the absence of having an A-line, you can't really get much quicker hemodynamic information outside of like skin color, temperature, condition, visual patient changes, heart rate changes, those sorts of things.
And we're not getting A-lines in the field, guys. Calm down. It's not happening.
One day, advanced practice. But so one quick note to make before we get out of here. In this study, they do take the effort to mention there's no statistical difference for rates of hospital survival or discharge with unfavorable neurologic outcomes. So again, and something that we try and do here at our journal club is we want to kind of educate and inform you guys on what's out there in the literature and what's coming down the pike. So this saying that there's no improved outcomes, improved discharges, there's so much cardiac arrest data that there's a lot of it. In my personal opinion on this, and I don't mean to speak for Dan or for Mike, is that life is a terminal condition. So we're never going to get more than probably 25% cardiac arrest survivability. That said, using these methods and using these data-driven techniques can improve a patient's outcome a little bit to try to improve them more once they're in the hospital. This isn't necessarily about giving norepinephrine after cardiac arrest to get them to survive after they get to the hospital. This is what we can do in the time to improve their outcome while we have them. Everything else we can kind of figure out and extrapolate later. But we want to know what you guys think. Leave the comments down below. Be sure to subscribe. Check us out at overrunems.com. For the Monday Afternoon Journal Club, Ed Bowder, Dan Schwester, and Mike DiFilippo, and we will talk to you all next week.
Take care.